Okay. So today what we're going to be doing, guys, is we're going to be finishing up with chapter 13. So in the previous two spreads, what we looked at what was specific phobia. And then we looked at what are the key symptoms or the key characteristics of people who have specific phobia. And then we looked at the biological, psychological, and social contributing factors that cause someone or that contribute to someone developing specific phobia. So today what we're looking at is we're just looking at some treatments, again, following the same biological biopsychosocial model. Okay, we're looking at some evidence-based interventions. Whenever you see this word in a question, don't get panicked. Evidence-based intervention basically means what kind of treatments or what kind of strategies are available for people with specific phobia to manage their symptoms better. Okay, we don't really use the word cure. Okay, specific phobia or any mental disorder is not something you can cure, but it's something that you can ease the symptoms, or you can reduce the symptoms, or you can manage the symptoms a little bit better. Okay, so that's the basic idea. That's what we're doing today. And we're going to look at it in terms of what are the biological evidence-based interventions, what are the psychological evidence-based interventions, and what are the social evidence-based interventions. Okay, so that's what we're looking at. Now, with the biological evidence-based interventions, what we're looking at are two specific types. We've got GABA agonists and we've got relaxation techniques. Okay, and we say that these are biological treatments because they affect the body. They affect the body's anxiety response. Okay, that's why we say these two are classified as affect the body's anxiety response. So, for example, they reduce a person's increased heart rate. They reduce a person's increased perspiration or increased levels of sweat when they see their phobic stimulus. So they basically affect the body's anxiety response, and thus they are biological evidence-based interventions. Okay, so the first one we're looking at is called GABA agonist. Now, if you remember in spread 13b, we talked about this idea of GABA dysfunction, okay, that in people who have specific phobia, GABA doesn't really act in the way that it should. It's not effective. Okay, it's not effective at reducing that overexcitation and that excessive neural firing that these people with specific phobias have. Remember, we talked about the example that if I have a specific phobia of dogs and I'm walking down the street and I see a dog probably 5 kilometers away, it's like so far in the distance, I can barely make out what it is. But the minute I see that dog in the distance, my brain starts overworking. It starts a lot of neural firing. Okay, all these neurons are presynaptic and postsynaptic neurons are communicating with one another. Like, oh my God, there's a dog. Oh my God, what am I going to do? Oh my God, how can I escape? Oh my God, what if the dog chases me down the road? All these thoughts start building up and rapidly coming in, getting sent between one another or getting transmitted. As that happens, you've got a lot of glutamate building up. And we said that usually in people who have, who don't have specific phobia or don't have anxiety disorders, GABA, it works properly, and GABA is able to come in and calm things down. Okay, it's able to regulate the activity of glutamate. In people with specific phobia, because GABA doesn't work the way that it normally should, all this excessive neural firing, all this excessive neural communication because of the overthinking and the paranoia comes about, but GABA can't help in calming that down. So the person's brain is in a state of overexcitation, but GABA can't do the best job that it can in calming the brain down. Okay, and that is what leads to the main symptom that people with phobias experience, which is anxiety. Okay, anxiety is the experience you have when your brain is overexcited, when your brain is over excessively kind of firing itself in terms of neural firing, in terms of communication between the pre and postsynaptic neurons. So because GABA doesn't work in the way that it should, and because GABA doesn't function properly in people with specific phobias, what we do is we try to synthetically or artificially, we could say even, increase GABA levels or increase the effectiveness of GABA in these people's brains by giving them a drug called benzodiazepines. Okay, benzodiazepines are basically used to calm down the brain and the body by reducing that physiological arousal and by basically doing what GABA should have normally been able to do, which is by reducing the overexcitation of neural activity and by boosting the effect of GABA. Okay, remember GABA was dysfunctional in people's brains who had specific phobia. So by giving them a benzodiazepine, what we're really doing is we're helping to help GABA work in the way that it normally would. Okay, we're trying to undo or reverse that dysfunction and allow GABA to function once again. That's what a benzodiazepine is. Okay, benzodiazepines are GABA agonists for that reason. And this is a very important term to remember, agonist. Okay, an agonist is basically any substance or drug that imitates or mimics the activity of a specific neurotransmitter. In this case, benzodiazepines mimic or they imitate the activity of the neurotransmitter known as GABA, because this is the neurotransmitter that is not working properly in people's brains who have specific phobia. Okay, so by benzodiazepines being a GABA agonist, they are able to actually act like GABA and boost the activity of GABA. As you can see here, an agonist basically causes a receptor to activate. So it causes, for example, GABA to activate. And the opposite of an agonist is an antagonist. An antagonist is like basically the opposite of an agonist. It means that we're not allowing activation of that receptor there. Okay, so a GABA antagonist would actually not imitate the activity of GABA. Okay, with people who have specific phobia, we want a GABA agonist because we want to see the GABA working in their brain. Okay, we want that receptor or that GABA to activate. We don't want it to become even more dysfunctional than it already is. So that's why we don't use an antagonist, we use an agonist. Why am I even mentioning the term antagonist then? Because this term came up in the 2017 VCA exam. And no one, or most students didn't know what it meant, okay? Because only some textbooks had mentioned this. Our textbook hadn't mentioned it, but luckily we did discuss them in conjunction with one another, so it was okay. But we have to remember that sometimes terminology that's not in some students' textbooks can come up in the exam. So we have to cover all bases, okay? So an agonist is basically something that mimics or imitates the effect of GABA, okay? Helping to improve the GABA functioning. An antagonist is something that doesn't imitate, okay? Remember, an antagonist is basically in English, like in novel study and stuff, an antagonist is the opposite of a protagonist. An antagonist goes against the protagonist. So similarly, if we link that back to psychology, we could say that an antagonist goes against the activity of an agonist, okay? If benzodiazepines are trying to imitate GABA and increase the levels of GABA in the brain, an antagonist is actually trying to stop that. An antagonist is trying to reduce the levels of GABA in the brain and work against benzodiazepines in this case, okay? So that's the difference between the two. Okay, a common example of a benzodiazepine is Xanax. Okay, Xanax is a very commonly used antidepressant. In fact, a lot of our benzodiazepines are antidepressants or are used in along with antidepressant medication, because benzodiazepines are, they are something that can help in reducing phobic anxiety. And we know that it's not just people who have specific phobias who experience anxiety. People with generalized anxiety disorder experience anxiety. People with depression experience anxiety. Even people with schizophrenia and other mental disorders like personality disorders experience anxiety. Anxiety is one of those things like stress. It's an overarching symptom that's characteristic of many different mental disorders. Okay, so that's the main idea behind benzodiazepines there. So this is just a more visual diagram showing you how it works, okay, showing you how benzodiazepine works. And I've just taken this from your book. So the first thing is that benzodiazepines are a GABA agonist, remember? And what did we say about GABA agonists? We say that they generally activate the receptor site. Okay, they activate that GABA. So what the GABA agonist or the benzodiazepine does is that it binds to the GABA receptor site, okay, on the postsynaptic neuron. The receptor site is always on the postsynaptic neuron. Okay, we learned that in Unit 3. The benzodiazepines, once they've binded or once they've been bound to that postsynaptic receptor site, what they do is the benzodiazepines actually increase the effectiveness of GABA. So whatever little GABA is available there at the receptor site, benzodiazepines boost the activity of that GABA, okay? And GABA, which was previously dysfunctional, which wasn't able to do its job and function properly to reduce the person's anxiety, is now able to have a better effect in terms of a better inhibitory effect. Now its performance has been boosted. So now it's going to be better able to reduce the neural firing, okay, reduce the likelihood that the neuron will fire. This is what we want to do, because remember we said when there's increased firing, there's increased anxiety. So in a person with specific phobia, we want to decrease the neural firing. We're not talking about them learning something productive. We're not talking about them memorizing. So in this example, we don't want excessive neural firing. We want to reduce it, okay? And what this helps to do is when GABA helps to reduce the neural firing, it also temporarily reduces neural communication, okay? What that means is, why we use the word temporarily is because if I take GABA once in my life, it's not going to help me with my anxiety for the rest of my life. I have to continue taking that particular drug, that particular benzodiazepine, in order for my anxiety to be continuously controlled. Okay, and just like we learned about when we talked about the lock and key process, the benzodiazepine and the GABA need to be the right shape or the right structure in order to fit. So here you can see it's a triangle, and you can see that our benzodiazepine is the same shape as the receptor site as well as the neurotransmitter. So glutamate is the neurotransmitter. This is the benzodiazepine. This is the agonist. Okay, and that blank triangle right in the middle is our receptor site. So you can see all of them are the same shape. We've got a matching shape there. So we can see that the lock and key process will be successful. Okay, and that the message or the GABA will be successfully transmitted across.
Miss,
that's the basic idea. You don't need to be able to draw this diagram, but just be able to understand all the different highlighted things that I've indicated here. Okay. In the study design, we call this response a short-acting anti-anxiety response. Anti-anxiety because it helps to reduce the anxiety by, again, reducing the neural firing. Short-acting because it's temporary. Okay, like I said, you have to keep taking the benzo every day. You can't just take it once in your life and say, okay, that's it, I'm good for life, I don't need to take it again. Yes, there's a question.
Miss Farwin.
Yeah.
Why do we need that drug? Don't GABA already inhibit firing?
Yes, in normal people, meaning in people who don't have specific phobia or other anxiety disorders. But like we said in chapter 12, people who have specific phobia or even people who just are generally experiencing a lot of anxiety, they tend to have GABA doesn't work in their brain as it usually does. Regardless of any mental disorder we have, guys, like in depression, for example, the neurotransmitter serotonin doesn't work properly. Most mental disorders are because of changes in brain chemistry, like neurotransmitters not working the way that they normally do. So for example, how I experience anxiety as someone who doesn't have specific phobia will be very different from the way a person with a specific phobia of dogs experiences anxiety. That's the basic idea. Their brain chemistry is changed, and that's why GABA doesn't work as well as it does in a normal mentally healthy person. That's why they need a helping hand in the form of benzodiazepines to manually or kind of artificially bring up their GABA levels. Does that make sense? Okay, so that's the basic idea. Okay, we have to remember people with specific phobia or any other mental disorder, their brains don't function in the same way that ours do. They don't have normal levels of neurotransmitters in the same way that we do. And even if they do have the normal levels of that neurotransmitter doesn't function properly. It's like defective. It's dysfunctional. It doesn't work in the way that it should. Okay, so that's the basic idea. If you know these 3 steps, then you're basically all good, or even if you know the 3 steps from the previous slide. Benzodiazepines are also known as benzos. Okay, if you listen to, I don't know, Post Malone or all these singers, they often talk about taking benzos. Okay, and this is because benzos are a prescription drug that is prescribed to people with mental health issues. Okay, so yeah, that's basically what benzos are and what benzodiazepines are and why they are helpful for people with specific phobia, because they help to increase the levels of GABA in the brain. That helps to reduce the excessive neural firing that these patients experience. Remember, guys, the main rule here, if I can get a little text box out just to summarize it, is that excessive neural firing, sorry, let me go straight from the beginning. Overthinking about the phobic stimulus equals to excessive neural firing. So pre and postsynaptic neurons over communicating with one another. Basically, that's what happens when we overthink, right? And this equals to increased anxiety. Okay. Increased anxiety. needs to be calmed down through GABA. I'm literally breaking this into like a million steps, but patient does not have enough GABA or it doesn't work properly due to dysfunction. Okay, and what this means is patient takes benzodiazepines, which are GABA agonists. This helps the GABA to work in the way that it normally should, which helps to reduce the excessive neural firing and thus reduces anxiety. Okay, that is the kind of summary, I guess, a more simplified summary of how that basically works or how that process works. Okay, so that's the basic idea there. Okay, if you want, I'll probably take a screenshot of this and upload it later on if that helps you to understand it better. Okay, that's the basic idea. Okay, so let's keep moving on. Are there any confusions, guys, about this topic? I know this is the most difficult treatment in my opinion because it's very biological, and I know the biology can be intimidating sometimes. That's why I'm spending a little bit more time on this. The rest of them are pretty straightforward. In the SAC, can we just say agonist instead of benzo? No, you have to say GABA. You have to say that benzodiazepines are a type of GABA agonist. Look, if you spell benzodiazepines wrong, it's okay, but you need to know that a benzodiazepine is a type of GABA agonist. And yeah, you need to know both terminologies there. Okay, so that's the basic idea. It's like me saying, guys, saying that benzodiazepines are a type of GABA agonist is basically like me saying Panadol is a type of painkiller, okay? Or, I don't know, Hennessy is a type of alcoholic drug, okay? Or that Coca-Cola is a type of soft drink. It's just categorizing that particular drug into what type of category it falls under, okay? That's the basic idea. Okay, so that's GABA agonists. Now, what are some limitations of GABA agonists? Because we do need to know a limitation for each of these. Some of the limitations, and you just need to know one limitation, by the way, from this slide. Some limitations are just like any other drug that you can take. Benzodiazepines or GABA agonists tend to have side effects, okay? You can get dizzy, you can feel physically weak, okay? They're just a drug, like any other drug or any other medicine. Benzos can actually cause such side effects. As benzodiazepines are a drug, and most drugs are addictive, people can also become dependent on benzodiazepines, particularly because benzos help you to calm down, particularly because benzos allow your brain to rest and to relax, okay? Benzodiazepines are generally a depressant drug, okay? They help you to reduce those levels of overexcitation. They help to calm the brain, okay? So people who stop benzos can actually have withdrawal symptoms. Because benzodiazepines are also a depressant drug, as we've just mentioned, they also induce drowsiness. Remember, we said that when you take a drug that's a depressant, you start getting brain waves that are associated with the early stages of sleep, like alpha waves, theta waves, delta waves, okay, and the later stages of sleep. So if you take a benzo, it's probably not a good idea for you to drive a vehicle or for you to operate machinery, okay? So people that are working in such industries where they have to do these behaviors shouldn't be taking GABA agonists or benzos to begin with, okay? But also, just like every other thing that a pregnant woman can't eat or drink or take, benzodiazepines are also added to that list, okay? You can't take benzos if you are pregnant or even if you're trying to become pregnant. So if you're a pregnant woman and you've got a specific phobia of birds, well, good luck to you because benzos are out of the picture. You can't take it, okay? So just learn any one limitation of benzodiazepines there. Alrighty, so moving on to our next biological treatment or evidence-based intervention, which is a lot more straightforward. It's breathing retraining. Now, if you remember when we talk about people with specific phobia, we often say that when they first see their phobic stimulus in the street or even very far away, they start to experience a lot of sympathetic nervous system activation, okay? One of the effects of having a sympathetic nervous system activated is a heightened or increased breathing rate, okay? The way that these people breathe when they see their phobic stimulus, like a dog across the road or a bird in the distance, is actually what we call as hyperventilating. And all of us know what hyperventilating is. It's a common word that most of us use. It's basically what SpongeBob is doing in this little GIF here, okay, where he's hyperventilating, probably a little less dramatic than that, but you know, you're breathing in a very rapid and irregular rate there, okay? And that's the basic idea, okay, behind benzodiazepines there. Benzodiazepines. That's the basic idea behind breathing retraining, okay? That you are trying to retrain the way that you breathe so that you're not breathing in such a way that you're hyperventilating. You're breathing in a way that's allowing you to be calm, that's allowing you to feel relaxed, okay? Because when you breathe in a calm and relaxed way, that kind of sends a feedback to your body that you are calm and that you are relaxed, okay? If you've ever started hyperventilating due to something or due to some issue, you would realize that the minute you start hyperventilating, your whole body starts to change in terms of its functioning. You start to get a lot more sweaty. You start to tremble in terms of your hands even start trembling, okay? It affects your whole body. It becomes a whole body response. So breathing training is this idea that we're going in and we're asking the patient to correct their breathing patterns or to change their breathing patterns in such a way that they're no longer hyperventilating, but they're breathing in a way that can allow them to feel calm and relaxed. That's the basic definition. Now, how would this be carried out? First of all, we would ask them to inhale through their nose and exhale through the mouth. A lot of hyperventilation, as you can see with SpongeBob here as well, you can see that he's breathing mainly through the mouth there, okay? He's not really breathing through, he's not really inhaling through the nose. So in order to prevent hyperventilating, what we can do is we can ask people to inhale through their nose and exhale through their mouth in a regular pattern, not in a very erratic or chaotic way, but just asking them to breathe in a way that's less frantic and less like hyperventilating. Okay, and these are some other ways, like we can ask them to try to breathe 8 to 12 times per minute and not more than that. We can ask them to breathe from their diaphragm, which is the area right under the chest. Okay, we can ask them to breathe in a regular way. We can ask them to track their breathing using an app like a Fitbit smartwatch or an Apple Watch. They've got a lot of apps for breathing nowadays as well. We can ask them to use an app like that. Okay, one of the limitations though of breathing retraining is that breathing is an automatic pattern, okay? There's nothing that's more automatic than breathing. We don't even think about it. It's like a reflexive response, okay? So asking someone to actually go and change something as automatic as their breathing is actually easier said than done, okay? It requires a lot of effort, a lot of patience, okay? And a lot of the time, people who have specific phobia might not have that patience to do that, okay? They might think it's too time consuming. They might expect things to work in 24 hours, but they find that they're still hyperventilating the next day. And so they give up, okay? A lot of these evidence-based treatments that are time consuming will increase the chances that a person will give up before it actually has a chance to work. And so those are two main limitations of breathing retraining. Okay, so that's basically breathing retraining. Now, when we're looking at your book, in terms of what your book says, these are just the step-by-step processes. Again, I've just put this in just because it's more visual, but it's basically the same content as the previous slide. There's nothing new here. I'm just showing you an image of how a person would apply this. So if you've got a fear of flying, for example, you practice that in-out breathing, the very regular calm breathing pattern in the weeks before your flight. And then when you get on your flight and you start to feel anxious and you start to feel like you're hyperventilating, you calm yourself down. You think about that specific breathing pattern you learned about, and you can consciously and manually calm down your breathing as a result of that. Okay, so that's just the visual, nothing new here in terms of content, the same as the previous slide basically, but just the visual pictures there are good. Okay, the other type of biological kind of evidence-based interventional treatment is called exercise. We've already talked about exercise in Unit 3 when we talked about stress. And it's basically the same thing, except rather than focusing on stress, here we're trying to focus more on anxiety, because we know anxiety is the main symptom that people with specific phobias experience, more so than stress, okay? It's almost more or less the same kind of effects though, okay? Exercise is good for building up tension, okay? When you're anxious, you have a lot of tension that builds up in your muscles, just like when you're stressed. So exercise can help you to work out that tension. When you are having when you are exercising, your better endorphins are getting released in your body. That allows you to have a lot of natural pain relief and feel good feelings, okay, feel good mood. Okay, certain neurotransmitters like dopamine and serotonin are also released when you're exercising, which allow for you to feel a sense of calm, feel a happy mood, okay? Exercise can also act as a distractor. It distracts a person from their phobic stimulus, okay? Again, this depends on the actual phobic stimulus the person is dealing with to begin with. So for example, if you're scared of dogs, going on a walk outside to a park where there's a lot of dogs probably isn't a good idea, but going to the gym might be a good idea because we know most gyms don't allow dogs to be inside, okay? So that's the basic idea. It depends on the person and the scenario. Again, a lot of these are very similar, almost identical to when we learned about exercise in Unit 3. It's just that you're linking it back to anxiety in this case as well, okay? So that's the basic idea. Alrighty, so now we're looking at some limitations of exercise. This is like common sense. Okay, think about why you wouldn't exercise, and then you can apply it to the same thing as a person with specific phobia. Exercise is a physical commitment. It's a time-based commitment. A lot of people maybe don't have time to fit exercise. They're too busy to work out. Okay. Also, some people might not be able to afford a gym membership. If you live in a very sketchy or dodgy area where there's not a lot of walking pathways, or there's not a lot of parks where you can just walk in a very safe manner, it's going to be hard for you to actually exercise outside, and you might not be able to afford a gym membership, which is expensive in most cases. Okay, people who are morbidly obese, who have a specific phobia, might not be able to exercise because they've got mobility issues, or they've got issues with movement, okay, or they've got joint pain, so they can't exercise in the same way others can. Also, we have to remember, more specifically to specific phobia, that people with any mental disorder experience a low mental state. Okay, when you don't have the motivation to get yourself out of bed in the morning, what makes you think the person's going to be feeling motivated to go to gym and, you know, press 100 kilos or something like that? Okay, it's not going to happen because they're not motivated to actually do that. So that's the basic idea. Okay. So again, just learn any one limitation for each. So any one for exercise will be fine. Just learn the one that's easiest for you to remember. Okay, so now we're looking at the psychological evidence-based interventions, or in other words, the treatments, and we're going to learn about two, one of which we've already kind of touched upon when we did chapter 10 with the sleep disorders, which is CBT, and the second one is systematic desensitization. So with CBT, we already know what CBT is. We know that it's basically this idea behind how we think affects the way that we feel, and that how we feel affects the way that we behave. Okay, we learned about this with reference to sleep in chapter 10. It's the same concept, guys, but what we're doing here is we're just applying this now to people with specific phobia. So rather than overthinking or thinking about your sleep patterns, now you're thinking about how you can have more positive thoughts, feelings, and behaviors surrounding your specific phobic stimulus there. Okay, so cognitive behavioral therapy basically combines cognitive and behavioral strategies to help people manage the thoughts, feelings, and actions or behaviors that are responsible for the anxiety symptoms that they experience. Okay, basically trying to deal with these negative automatic thoughts that come into the person's head. Okay, when they see a dog in the distance and they think, oh my God, that dog is there, it's going to run to me in the next minute and maul my face off. Okay, those negative automatic thoughts, which are sometimes very, you know, represent cognitive biases as well, like catastrophic thinking. All of these cognitive biases can be fixed or can be managed using CBT, because in CBT, we're changing our judgments, we're changing our interpretations, and we're changing the way that we look at that phobic stimulus. Okay, so for example, if you have a phobia of flying, your negative automatic thought might be like, oh my God, flying is dangerous, or the plane will crash the minute I get onto it. Okay, so that's the basic idea. And you can see how that would then affect the person's emotions. Okay, that thought affects the person's feelings or emotions. They're terrified, and that feeling or emotion now affects their behavior, which is they refuse to fly or they avoid airports at all costs. Okay, so that's the basic idea. There's a connection between the C, the B, and the, sorry, not the C. What did I do? No. There's a connection between the emotions.
That's the T, miss. That's the thought. The C is the T.
Oh yeah, my bad. Sorry, I just lost my
T
for a second. Okay, so yeah, the thoughts and the feelings and the behaviors there. So that's the basic idea. Okay, so you can see how those three are connected there. Okay, so that's CBT. It's the same basic concept as chapter 10, guys. All you're doing is you're now applying it to specific phobia, thoughts about specific phobia, feelings about specific phobia, and behaviors. And we said the main type of behavior people engage in is called avoidance behavior. Okay, this is the type of behavior that people with specific phobia show. Okay, if they're scared of seagulls, they don't go to the beach because they are, they have a specific phobia. So they stay at home, they lock themselves in their room, and that's avoidance behavior. They're avoiding the phobic stimulus. Alrighty, so just to show you guys, again, the cognitive component, it's just telling people that, telling people or asking people or encouraging people to change the negative and irrational ways in which they think about the phobic stimulus. So rather than them, if they say, oh, I'm so scared of dogs, I feel like if I ever touch a dog, it'll bite my hand off. The psychologist might ask them, well, has that ever happened to you in the past? Do you think that's actually realistic? Is that a really practical way to think? And then eventually the person starts to their eyes start to open and they start to realize that some of their thoughts are actually quite exaggerated or they're quite illogical. Okay, when you actually start thinking about your negative automatic thoughts about the phobic stimulus and you start saying them out loud to someone else, some of these patients actually see how you would say irrational or illogical those thoughts are to begin with. Okay, so the psychologist works with the patient to first identify the negative or unhelpful thought, which is, oh my God, touching a dog will lead to my arm getting bitten off. Then the psychologist asks them to carefully examine that thought. So think about it. Is that really logical? Has that ever happened before? And then basically the psychologist would ask them to evaluate how realistic or helpful that thought is. So does thinking in this way help you really? Have you ever really seen someone's arm being bitten off after touching a dog? Okay, and then the patient is able to evaluate that thought. Okay, so that's the basic idea behind the cognitive component. And if we're really going into it in depth and talking about the behavioral component is just using any of those strategies we talked about before, like exercise, breathing, retraining or relaxation techniques, muscle relaxation methods, all of these things, meditation, all of these things can help or can be incorporated as a part of the behavioral component of CBT there. Okay, so that's the basic idea. So in one part of CBT, we're addressing the negative thoughts and feelings, which are all to do with the mental processes. And in the second part of CBT, in the behavioral component, we are dealing with the the actions, the problematic actions and the problematic avoidance behaviors there, and trying to get this person's body to engage in behaviors that reduce anxiety rather than contribute to anxiety. Okay, so these are some unhealthy thoughts and behaviors just taken from your book and very much linked to what we talked about. I already talked about catastrophic thinking before. So these are just some examples of thoughts and cognitions or thoughts and behaviors there that can contribute to or maintain a person's specific phobia there. Okay, so this is another example from your book, just showing you with the phobic stimulus of bugs. Okay, the thought could be that a person believes that if they leave their house, they will be confronted by bugs or bugs will start crawling all over their face. That's a thought. That's a negative thought. The negative behavior would then be the avoidance behavior. The person stays in their house, they never leave their house. And both of these thoughts and behavior together contribute to the stress response, which is the fight, flight, freeze response. And this is connected to the activation of our sympathetic nervous system, okay, which we learned about in chapter 3. Alrighty. So some of the limitations of CBT, just like breathing retraining, just like all the other things that we've talked about, it's easier said than done. CBT is easy to talk about on a PowerPoint slide or on a piece of paper, but it's not easy to actually practically conduct. The reason being that avoidance behaviors allow people to feel sense of relief, okay? Avoidance behaviors create this sense of negative reinforcement where you're removing a negative or unpleasant stimulus, the phobic stimulus. By not going to the beach, I'm avoiding seagulls. Okay, by staying at home, I'm avoiding the seagull. That brings me a sense of relief. And that relief causes my behavior of avoiding seagulls to be negatively reinforced. So the next time there's a chance that, oh, let's go to St. Kilda Beach, let's go to, Brighton Beach. The next time someone asks me to go to the beach, what am I going to do? I'm going to stay at home again because that avoidance behavior has been negatively reinforced. So these behaviors are very strongly set in the patient who has specific phobia. It's not easy to just put them away because of some behavioral therapy. Okay, it takes time. And like we said, it's easier said than done. Okay. Also, we have to remember that a lot of phobias are developed through traumatic situations, and it's very hard for a person to just rid themselves of a trauma or of a traumatic situation they've gone through. It takes a lot of therapy, it takes a lot of time, okay? And some people may not be happy that it's taking longer than expected, so they might, again, give up. Okay, so those are some limitations there. You just need to know any one. Alrighty, the next type of psychological evidence-based theory that we look at is systematic desensitization. Systematic desensitization is this basic idea that rather than making the patient get exposed to that phobic stimulus straight away, we are actually doing it in a step-by-step fashion. Okay, that's what systematic desensitization means. When we're desensitizing someone to something, we are reducing their fear to it little by little. We're making it easier for them to not get affected by something. Systematic is another word for step-by-step. Okay, so systematic means step-by-step, and desensitization means we're trying to reduce their fear response to that particular thing. We're desensitizing it to them so they don't become as sensitive when they are exposed to that phobic stimulus. So systematic desensitization involves progressively. Another word for progressively is gradually or little by little. Exposing the client to increasingly similar stimuli as the CS. Remember, the CS is the conditioned stimulus, which is basically the phobic stimulus, to gradually desensitize them to the conditioned stimulus themselves, such that the conditioned stimulus no longer produces the fear response. So we're showing them little bits and little glimpses of that particular phobic stimulus that they're scared of, and we're doing it slowly. We're easing them into it, okay? We're not showing it to them all at once and making them traumatized again. We're easing them into it. And as we ease them into it, they will eventually not show the phobic response. Yes, it is extinction. We're extinguishing the conditioned fear response. Okay, so that's the basic idea. Okay, basically when we're looking at, and I'm going to show you guys an example, okay? When we do systematic desensitization, our first step that we do is we create a fear hierarchy. So this is basically sitting with the patient and talking about what their specific phobia is, and then basically ordering the tasks. So if this person has a specific phobia of dogs, we ask them, okay, what's the scariest thing out of a fear level of 0 to 100 that you would say? And that's our topmost task. Okay, that's what our goal is. We want to reach that. That's our goal. That's the top of the hierarchy. Then the person says, okay, if several large dogs were around me and they were licking my face, I would be mortified. I would be horrified. So we put that as a 90 fear level. Okay. And you can see that the first task on the fear hierarchy is very mild. It's only looking at pictures of small and large dogs, maybe in a book. Okay, it's only 30 out of 100, which is probably manageable. But for some people with specific phobia, even this can be too much. It really depends on how severe your specific phobia is. Okay, so this is quite mild though, because it's right at the bottom of the hierarchy. Okay, in between, you can see as we go up, you can see the number of the fear level starts to increase, which shows that there is a progressive increase in the phobic stimulus, becoming closer and closer to approaching the actual real thing. Okay, you can see in some of these, watching Animal Planet dog shows, watching a real life dog children's movie, these are not actual real life dogs, okay? These are just dogs in books or movies. But as we move closer and closer to the top and the fear level starts to increase, you are actually encountering real dogs in these situations, okay? So that's why as you encounter a real stimulus there or real dog, the fear level starts to go up further, okay? Now, how is this done? Basically, the patient is taught a relaxation technique, like they're taught proper ways to breathe or breathing retraining. And as they go through each step, if they start to hyperventilate when they're watching the children's movie about the dog, they will start to breathe in the normal way possible. So they'll start to use those breathing retraining techniques that they were taught. Okay, so that's the basic idea with breathing retraining. So we're coupling or we're pairing the relaxation technique with the task. Okay, it doesn't have to be breathing retraining. It could even be a small exercise that you do that helps you to calm down. It could be a little period of meditation that you do. Okay, whenever you feel fear at any point of these tasks, if your fear level starts to go up or you start to get anxious, you use that relaxation technique to calm yourself down, to allow you to get to the next step, allow you to get to the next step, and allow you to get to the step after that. Okay, that's the basic idea. So that is what a fear hierarchy is. And what we're doing with the patient who has the specific phobia is we are going through this fear hierarchy. And remember, this is not a 24-hour thing. This is something that might take months. It might even take years for some people. Okay, we're going through it step by step. If the person has a panic attack here, we move all the way back down to the start and we're back to square one. Okay, so again, we want to make sure the person is confident and doesn't show any anxiety response when they get to this stage. Then we can say that there has been extinction of the conditioned phobic response. Okay, that's the basic idea. Alrighty, so this is again just a picture from your book. I like the pictures in your book, and this is another example as well that shows you, again, we're teaching them the relaxation technique, would be breathing retraining, for example. We're creating the fear hierarchy. You can see here that the fear hierarchy, or the last task that they're going to have to do, appears to be the scariest task. Okay, directly touching a bug. That is the most fear-inducing stimulus, which is why the arrow is there. Okay, whereas reading about bugs is not as scary, so it's something more manageable, it's more mild, something that most people should be able to do. And the ones in between, we can see as we get closer and closer to the last most fear-inducing task, you're dealing with actual bugs or real life bugs. You're no longer dealing with pictures or cartoons or photos of bugs. You're actually dealing with the real bug itself, because you're getting closer and closer to meeting your actual phobic stimulus in real life there. Okay, we do it in a step-by-step manner. And as we go through each of these tasks, we use a breathing technique or a relaxation technique. And eventually we continue this systematic desensitization until the most fear-inducing stimulus on the board or on the hierarchy can be faced without producing the phobic response. So if my patient can directly touch a bug and doesn't have a panic attack or anxiety attack, I can say, yep, we were successful. You no longer have specific phobia of bugs. You are basically all good now. Okay, I want to avoid using the word cured because people can relapse back into specific phobias, but for the moment, you've managed your anxiety symptoms and looks like your specific phobia is no longer going to be an issue. All right, so that's the basic idea. Some limitations of this systematic desensitization are, number one, just like a lot of the other treatments or evidence-based interventions we've gone through today, it can be very time consuming. So as Elmo says, why does it take so long? Okay, a lot of people can't actually wait that long. Okay, people don't have patience. Generally, patients don't have patience. Okay, they don't have a lot of time to waste. And so they may actually not be able to make the time commitment. Okay, they might be like, what, it's going to take a year for this to work, whatever, I'm out of here, I can't do this. Okay, so you need a lot of patience to be able to engage in systematic desensitization. A lot of people may also feel frustrated. Think about it, if you were a patient and you were almost at the top of the hierarchy, you were almost going to overcome your fear, but in the second last task you had a panic attack, and now your psychologist says, okay, whoops, you've got to go all the way back to square one to the first task. You're obviously going to be upset. You are going to be frustrated there, okay? And you might give up halfway as a result of that, okay? Also, we have to remember that even though systematic desensitization does take a step-by-step approach, some people can't take that. Even a step-by-step approach might be too much for some people, okay? It's enough to cause them distress. And again, this is because a lot of the time with specific phobias, people develop specific phobias after a very or extremely traumatic experience or encounter with the phobic stimulus, okay? And traumas are not that easy to just ignore, okay? So that's the basic idea. So learn any one limitation there from this slide. Okay, the last thing we're looking at for today is a little bit more straightforward. It's the social evidence-based intervention, okay? It's the basic idea that the patient who has the specific phobia, for example, if this girl has a specific phobia of, we say birds and dogs, let me say clowns. If this girl has a specific phobia of a clown, she can't actually just deal with this on her own. She needs the support of people around her. She needs the people around her to have the proper knowledge in order to not judge her, in order to not pass her off and say, oh, you're just being dramatic, or you're just being a drama queen as usual. Okay. You need to have those people around you, whether it's your mom, whether it's your sibling, whether it's your husband or wife or partner. You need them to basically have the knowledge about your condition, to understand that you're not being dramatic, and so they don't put stigma on you, or they don't stigmatize you for having that condition. Okay, a lot of the time patients have a lot of suffering, okay, and that suffering is not always well understood by the people around them. The best people who need to know what a person with specific phobia is going through are their families, okay. So psychoeducation is this idea that we educate, or we provide information about a specific mental disorder, in this case specific phobia, to the patient, as well as, more importantly, to their carers, their parents, their guardians, okay, their loved ones, their supporters as well, okay. These are the people who need to be there to support this patient, okay, who's going through this tough time. If this mom doesn't understand that specific phobia is a serious disease, or serious mental disorder, and forces her to come with, forces her daughter who's got a specific phobia of clowns to come with her to the circus, that's probably going to be a traumatizing experience for her daughter, and she doesn't even realize what she's putting her daughter through. So psychoeducation can stop traumatic incidents and misunderstandings from happening in the first place by ensuring that families are on board, husbands are on board, wives are on board, carers, parents, whoever is a supporter or a person that's close to the patient can have an understanding of how to best deal with that and how to best comfort the patient. Okay, that's the basic idea. There are two main goals of psychoeducation. The first goal is to challenge the unrealistic or anxious thoughts, and the second one is to not encourage avoidance behaviors. So challenging unrealistic and anxious thoughts is just literally what the name suggests. Okay, as a parent of someone who's got a specific phobia, you want to make sure that you're not encouraging those thoughts, okay? When a child says, oh my God, there's a spider, the mom shouldn't come up to the child and say, oh my God, yeah, there's a spider. Oh my God, what are we going to do? The mom's got to be a little bit more responsible, a little bit more role modeling good techniques. As we learned in observational learning, kids look up to their parents. So if the mom says something like, you know what, like, we can deal with this, or you know what, we're bigger than the spider, why should we be scared of the spider? The kid might actually be able to challenge those unrealistic thoughts that they're having, okay? The child themselves can also do this. They don't always need their parent to help them, but if you're an adult and you've got a phobia of spiders and you think, oh my God, spiders are going to crawl into my ears while I sleep and eat my brains out, that's an illogical and irrational thought, okay? That's an example of catastrophic thinking. But you can actually start to think about this idea that a lot of the time, the area that I sleep in the house doesn't have a lot of spiders. Usually it's very clean. There's no cobwebs, okay? First of all, spiders don't often crawl up beds. They usually just stick on the wall in one side of the room. And usually, even if they were to crawl up the bed, what are the chances of them actually getting into my ear? Okay, so you start challenging the thought and you start looking at the actual practicality of that thought becoming a reality. So that's what challenging unrealistic and anxious thoughts is. And the second part of psychoeducation is, this is another example. So taking an unhelpful and unrealistic thought, changing it into a more realistic and balanced thought. And if you think about it, this part of psychoeducation reminds us of CBT, okay? Changing those negative thoughts to more positive ones, okay? That's the basic idea. And the last thing that we're going through is the second part of psychoeducation, which is not encouraging avoidance behavior. So like I said before, parents can model good behavior. So rather than a parent screaming or running into the toilet and closing the door when she sees a spider, she might actually, you know, walk up to the spider and tell the spider, I'm not scared of you, when her child is there observing her, okay? And so the child might then role model that same behavior that they observe. So the next time the child sees a spider, they might not run to the other side of the house. They might try to confront the spider themselves. So that's what we mean by modeling approach behaviors. Another effective way is that we try to teach the child that avoidance behavior doesn't really get us anywhere, and that avoidance behavior is actually bad in the long run, okay? This is obviously difficult to do when your child is very young, but older children might be able to understand that, okay? Avoidance does not equal to recovery, okay? Sometimes, and I think we talked about this in the last chapter, sometimes we can also use positive reinforcement to actually reward a child. So if we say, okay, I know you're scared of dogs, but let's go to the park and, you know, let's just sit on the bench. If a dog comes about, we'll go back to the car. and let's see how you go. If you can do it, then I'll give you a lollipop, or I'll buy you your favorite Transformers toy that you always wanted. Okay, so you're able to use positive reinforcement, especially with very young children. It doesn't really work with older children, but with very young children, you can probably coax them into approaching their specific phobic stimulus rather than engaging in avoidance behavior. Okay, so that's the basic idea. Okay, so that's not encouraging avoidance behaviors. The basic idea with any of the stimulus, any of the evidence-based interventions we've looked at today is that we want to not encourage avoidance behavior. Okay, we want to make sure that we don't avoid the phobic stimulus. Remember, avoidance is not a cure. Avoidance is not good for people with phobic stimulus. Avoidance does not equal to recovery. You're never going to recover or get better or gain better control of your symptoms if you're always avoiding the phobic stimulus. So approaching a dog, if you're scared of dogs, even if you're having a little bit of an anxiety response there, at least you're seeing for yourself that the dog hasn't yet bit your arm off, or the dog hasn't actually killed you just yet. Okay, even though this guy's arm appears a bit abnormal, but yeah, that's the basic idea. Okay, what are the limitations of psychoeducation? Obviously, parents have to be on board in order for it to work. A lot of parents are very culturally minded or old-fashioned. Okay, they might not actually still believe in psychology, and they might not actually believe in specific phobia, even if a psychologist tells them about it or informs them about it. So they might be like, whatever, stop being dramatic, blah, blah, blah. Okay, a lot of people need to be on board for it to work. Okay, and because other people need to be on board for it to work, there's a low level of control that the person themselves has over that specific phobia. You can't control whether your parents believe in you or not, and so that can be a limitation. Also, in a lot of cultures, we have this thing called stigma against mental disorders, and specific phobia is one of those things that is stigmatized. Okay, particularly, for example, your mom and dad grew up with dogs and they love dogs, and dogs are like their most cherished pet, and then suddenly you develop a phobia of dogs. They're not going to be having any of that. They are not going to take you seriously. Okay, which is generally what happens. And again, stigma does play a big role in a lot of mental disorders. Okay, I believe that's the last slide. So this is just, again, just a summary of everything we've gone through. Okay, so that brings us to the end of chapter 13. So I'm just going to stop the recording.